Hey guys, I'm Kevin Budashevsky, and this is Features of Renal Disorders. So here's an awesome table from the text that covers the big picture changes seen in the disorders that we'll cover. So let's begin. In both Bartter and Gittleman syndrome, the blood pressure will be normal. Similarly, in both disorders, the plasma renin and aldosterone will be increased. However, remember that in Bartter syndrome, it's a disorder that's characterized by a defect in the thick ascending loop of Henle. It affects the all-important what cotransporter? Well, that would be the all-important NKCC, or sodium potassium chloride cotransporter. Therefore, it presents similarly to chronic loop diuretic use. Because of this, the urine calcium will be increased. Now, do you remember the primary defect in Gittleman syndrome? Correct. The disorder results from an absorptive defect of sodium chloride in the distal convoluted tubule. It presents similarly to chronic thiazide diuretic use and will thus have low serum magnesium and low serum calcium. In Liddell syndrome, there's actually a gain of function mutation that results in increased sodium resorption. And because of the increase in sodium, the blood pressure will be increased. In the absence of any pathology, what physiologic system results in sodium retention at the expense of potassium? Good, that would be the RAS system, specifically aldosterone. Because of the hypernatremia and hypokalemia seen in hyperaldosterone and also in Liddell syndrome and syndromes like it are sometimes called syndrome of apparent mineralocorticoid excess. Note the word apparent here. Aldosterone is not actually high, but due to the gain of function mutation, the nephron's responding as though it were. How do you think this pathologic increase in blood pressure will affect the physiologic renin-angiotensin-aldosterone system? Right again, this increase in blood pressure will shut down RAS, resulting in a decreased plasma renin as well as a decreased aldosterone. In SAME, the exact same changes are seen. However, in SAME, this results secondary to an excess of cortisol in cells that are enzyme deficient, leading to an increased mineralocorticoid receptor activity and thus hypertension. Do you guys know what enzyme is classically deficient in this syndrome? Good, that would be 11-beta-hydroxysteroid dehydrogenase. A bit of a mouthful, but if you're a gunner, it might be worth committing to memory. Moving on to primary hyperaldosteronism, the story isn't all that different. Because there's a pathologic increase in aldosterone, the blood pressure will, of course, increase. And because the blood pressure increase is abnormal, it'll shut down the physiologic RAS system, decreasing plasma renin. Do you know another name for this disorder? Good. Might have guessed from the slides that it's also called Conn syndrome. With excess ADH, what do you think the blood pressure would be? Well, since ADH causes the reabsorption of water through aquaporin channels in the collecting duct, you'd expect increased water, and therefore the blood pressure should be normal to high. With water retention, would you expect the RAS system to be up or down-regulated? Good, it would be down-regulated, so both renin and aldosterone will be down. Although it isn't in our chart, what would you expect the sodium to be? Well, sodium is a surrogate for total body water, and as there's excess free water in SIADH, patients will commonly get hyponatremia. Finally, in the situation of a renin-secreting tumor, all the lab values will, of course, increase. Renin is the starting point for the RAS axis, and if there's excess amount of renin in circulation, the downstream consequences will be an increase in both plasma aldosterone and a subsequent increase in blood pressure, secondary to aldosterone-mediated salt and water retention.